Mission to Margin is the business of healthcare.
And we want pharma to be in the game with us. No outcome, no income. Meaning, if we have a readmission, we gotta eat it. If we have a hospital-acquired infection, we gotta eat it. If we chose the wrong antibiotic, we gotta eat it. If we didn't follow through on the chemotherapy and we didn't describe the side effects, and patient can't go home for 2 days, and on and on. So to be at economic risk with us, that's something I would love to see pharma do more of that.
Buyers in the healthcare marketplace with whom you're speaking expect you to be the premier, have the expert knowledge of your capabilities and understand how, not just the person with whom you're speaking, how this might impact their world, but how does it impact the organization and individuals along the chain in that organization? And then how do your solutions, notice I said solutions, not products, right? How can you come up with a solution that impacts the critical business needs or the critical practice needs that your customer has?
That was Dr. David Nash, Dean of the Jefferson College of Population Health, and Brad Ansley, Director of SPI Health, the life sciences practice of Sales Performance International. Health systems manage the selection of pharmaceuticals and other supplies through a health systems pharmaceutical and therapeutics, or P&T committee. This committee facilitates consensus amongst medical staff, administration, finance, supply chain, and departments such as pharmacy. In this interview, we challenge the status quo of the contemporary supplier health system relationship, which is a complex web of supply chain business relationships, price negotiations, and market share trade-offs. We explore how population health is leading innovators towards shared risk contracts between their suppliers and the health system. These create a vested partnership with the potential to achieve enormous cost and quality improvements. As we will discuss, there are many disincentives and risks to adopt this innovation and massive change to both the health system supply chain function and the supplier's commercial sales operations. Dr. David Nash is the founding dean of the Jefferson College of Population Health, the nation's first academic institution focused on that specialty. Dr. Nash is also a practicing primary care physician, an active member of the Jefferson Health P&T Committee, and a much sought-after speaker on population health and healthcare policy. Brad Ansley is a global expert in helping pharma, device, and other healthcare suppliers retool their sales organization for population health. He has worked with some of the largest pharmaceutical and device companies around the world in redefining their sales process, determining new sales competencies, and measuring and elevating proficiency. In addition to helping found SPI Health, Ansley has launched multiple pharmaceutical products and has personally trained thousands of pharma sales reps around the world. I began by asking Dr. Nash to define population health. Dr. David Nash, Brad Ansley, thank you so much for joining the business of healthcare today.
You're welcome.
Glad to be here.
This is exciting.
So you have a green button
Yes.
on your jacket. Tell me about that green button.
So population health, what exactly is that?
Yeah.
Pretty great, isn't it? So in 2003, Dr. David Kindig, then at the University of Wisconsin in Madison, writing in the American Journal of Public Health, said, hey, public health is great. You know, AIDS prevention, obesity reduction, driving 55 miles an hour, eat your fruits and vegetables, get vaccinated, get a flu shot. Who could argue with that? It's like the Eagles winning the Super Bowl, right? Outstanding. But in his 2003 paper, he also said, we're not thinking about the broader issues, the social determinants of health, what role poverty and education play in achieving good health, what does all this cost, and what is the quality and safety of what we're delivering. So we embraced that term in 2008, almost 10 years ago now, when we started the nation's first college of population health. And I think in 2010, 2 years into after the creation of our college, of course, Obamacare was a rocket ship to promote the concept of population health.
Now, you sit, Brad, in the other end of the healthcare delivery system, if you will. You focus in the commercial delivery. Talk about that.
So I'm director of SPI Health, And SPI Health is Sales Performance International's dedicated life sciences practice. It's a global practice. And what we do is help sales organizations overcome the change and the challenge and the disruption that's going on in the marketplace today. And so we do that by helping them understand where they are today and where they need to be to align with today's expectations of providers and payers, et cetera. And then we assess them for where their proficiency levels are and the competencies that are needed to move forward, to move out of that old model, if you will.
When you think about that, and I'm gonna take a hypothetical view.
Mm-hmm.
I'm the CEO of a large employer. I'm spending X millions of dollars on my employee health plan,
Mm-hmm.
and I know in that 5% maybe is ending up covering the cost of sales. I've got a broker who's probably taking 2.5% of my total medical spend. And I've got, Roche reps calling on hospitals and physicians that take their commission. Is that necessary? Is the spend necessary as a commercial function?
Yeah, and that's a really good question. And that's being examined every year since I've been in the pharmaceutical industry, which was started back in 1987, I believe, 86 or 87. But now, sellers are at a different point in the sales conversation when they enter the picture. Right, the buyer, if you will, has already done a lot of research, already understands a lot of the information. So today, the seller has to be able to provide value, right? And they have to have the competencies and be trained on the competencies and have the proficiency level of those competencies to have, let's say, a dialogue that focuses on what are your needs, not let me tell you what you need from me, right? And by the way, here, if those are your needs, how does that impact your whole organization? And I have to understand that organization. I have to have situational awareness to be able to have that conversation along the buying spectrum, if you will. And so those are some of the competencies that we help shift and transform, help companies shift and transform. And quite frankly, we can do it quicker and at less risk than them doing it themselves.
Yeah.
That's the key.
Wow. It's a tall order.
Rapid change.
Yeah.
We talk about the rapid change.
Yeah, well,
that you're observing.
let's connect the dots with Brad's great answer. So I've been on the P&T committee at Jefferson since 1990. It's a long time. And I chair one of the subcommittees which is involved with medication quality and safety related issues. So adverse drug events, medical error, and so on. And, ages ago, reps called on us. Of course, I haven't spoken directly to a rep in my role as a primary care doctor in probably almost 10 years now, right? So the kinds of people who we want to chat with from industry are the folks who are educated by Brad and others who understand just how fast the system is evolving. I think the folks carrying the bag have a big challenge today. And if you look at Jefferson Health, it's a great reflection on the marketplace, meaning when I got to Jefferson, we were one hospital, and now we're 14 hospitals. We're struggling to create an enterprise P&T committee. We're struggling to get better outcome measures. We're spending tens of millions of dollars in acquisition cost across the whole spectrum of products. So we need people from industry who aren't just going to give us stuff we could get online or read in a journal. We want to understand, well, do you want to work on a project together? Do you want to gather some data? You want to write a paper? You want to look at some research related activities together? That's what I'm interested in. I think the days of just the fella or gal carrying the bag and rehashing what I could read anywhere, those are long gone. But not every big company is up to speed, so they need additional training, no question.
There was a passion story here. There was a passion starting point that got you to that moment.
You bet.
Talk about that just a moment.
So I'm a primary care general internist. I've been in academic medicine my entire career, 30 years. 28 of those years at Jefferson University in Center City, Philadelphia. I came to Jefferson in 1990 as the only physician faculty member who had also been to business school, because the dean at that time was prescient and was preparing the faculty for 1991, 2, and 3, and Hillary Care. Remember that? Seems pretty quaint now.
Yeah. Pretty painless.
Pretty painless, right. Although, remember, Mrs. Clinton held up a book about hospital-based outcomes, was a potential proponent of drug price controls. So back in 92, 93, that was pretty heady stuff. So I came to Jefferson from Penn Medical School, where I was a Robert Wood Johnson clinical scholar, had gone to Wharton. It was just a really important time of my training. I came to Jefferson as a brand new assistant professor of medicine, and we created an Office of Health Policy, kind of a corny term, but it was basically a catch-all for Nash is going to do stuff that no other faculty member really cares about or is trained in, and he's going to think about the cost of care and the quality of care. 13 years later, 2003, we had built a pretty considerable research engine, publication engine, internal education engine, and a new dean created a medical school department of health policy. Now, it doesn't sound like much, but in our world, a brand new department is a big deal. And I actually modeled our department after a handful of other such departments in other medical schools, including my good friend, Dr. Mark Chasson at Mount Sinai Medical School, now, of course, president of the Joint Commission. Okay, fast forward 2007, we get a new university president, and the very short story there is Dr. Robert Barchi, who had come from the University of Pennsylvania, a really incredible guy, member of the Institute of Medicine, research neurologist, MD, PhD, super smart, now president of Rutgers. But in 2007, he led a university-wide strategic planning session. And to cut to the chase, this strategic plan said, you, Dr. Barchi, are going to build 2 new schools, a School of Pharmacy and a to be determined. And that to be determined became the nation's first college of population health. So how did I get into the scrum? Well, I was the chairman of the Department of Health Policy. If you were a university president, you got your guy is already here. You can get him on the cheap. And he said, you know, you don't need a spectrophotometer and a laboratory and any of that. We're just going to take your department out of the medical school. We're going to give you degree granting power. We're going to make you the dean, and then you're going to build me this brand new school. And in a minute, that's the story.
Yeah, we like to talk about, there's an old thought process that relationship, you know, everybody does this relationship selling, right? Well, the best way to have a good relationship is by providing value.
You bet.
And the strongest relationships are built on value. And to understand how that enterprise works and to have that fluency, to be able to have that conversation, not only to put your point of view forward, but to have the dialogue. So what do you need?
I think today the system is in such rapid evolution in terms of bundled payment, creating accountable care, all of that. That's going to require a lot of expertise on the part of pharma, all up and down the chain of command.
I agree.
What percentage of the U.S. healthcare dollar spend do you think is exposed to risk today?
Well, I think it's probably about 10-15%.
Yeah.
It's modest.
Yeah.
But so that brings up the broader issue is where do we think the world is going?
Yeah.
I think the world is inexorably headed to the world from volume to value. I don't see how we could get around it. Is it going as fast as David Nash would like it? No. I think bundled payment is the way to go. Let's put it this way. The research evidence is solid. You want to change clinician behavior, you got to change the economic incentives. And the way to do that is no longer just the gatekeeper model of a primary care doctor like me making every decision. That's not it. What we need is to involve the specialists, everybody's in on the act, and the delivery system itself. Here's your pot of money. Now you guys and gals figure out what's the best attack. Today, that's 10 cents on the dollar. Let's not forget, no matter what party you're in, Medicare is committed to 50 cents on the dollar by 2020. Well, we're 2 years away, less than 2 years. So we got to get moving, and we want pharma to be in on that 50% by 2020 as part of the deal. 18% of the GDP. So that's today, 2018. That's roughly now $3 trillion. Pretty incredible, right? The best experts believe that of the $3 trillion, 10% is the pharma spend, right? So it used to be 7 cents, 8 cents. Now we're talking a dime or more of every dollar spent. So that is a lot of money going to pharma. So looking at it another way, it's $10,000 per person in 2017 of healthcare spending, including children. So we have to ask ourselves the question, getting back to Brad's great comment about value, are we really getting 10 grand of value for every person in our family? So I have 3 grown children plus the boss, that's 5 of us. So 50 grand. Did we get $50,000 worth of value out of the healthcare system last year? Hardly.
It's a big problem. We understand from data that was published a couple of days ago, perhaps price.
Yeah.
What's your reaction to
well,
that?
You're on top of the details. That's wonderful. Yeah. So people ask me all the time, okay, big mouth, why is healthcare so expensive?
Yeah.
That's a really interesting question. It's got 3 easy answers, right? Generally speaking. 1, we do more stuff at a greater intensity across the lifespan than any other nation on earth, right? So my 95-year-old father-in-law, God bless him, still alive, has all his marbles. He just had some laser prostate surgery, and nobody thought a second about it. I've got an uncle in Florida, 92 years old. He's going to have a TAVR in a group that has done 300 TAVRs in men over 90.
Wow.
Wow. So number 1, greater intensity of service than anybody else in the world. That's 1. 2, more expensive. So on a price comparison basis, we charge a way higher price. And number 3, salary. So salaries of healthcare workers in the US are way out of whack compared to the rest of the Western developed world. So Zeke Emanuel's paper in JAMA, lots of other great people looking at this. So intensity of service, price, salary. Those are the major components. And I think you'd have to say part of number 1 is diffusion of new technology. And doctors, we love our new toys, and we don't give up the old toys. You can't take my old toy away. I want to use that and the new toy, and yet we don't really focus on the outcome and what we get for the buck that we spent. But those are the 3 reasons why it's so expensive.
Take me through the idea of situational fluency. Mm-hmm. Take me through that concept.
Right, so situational fluency is understanding several pieces of information. Number 1, what your capabilities are as an organization. People, buyers in the healthcare marketplace with whom you're speaking expect you to be the premier, have the expert knowledge of your capabilities. Mm-hmm. The other is to understand the buyer side of it, right? Understand their business and understand how, not just the person with whom you're speaking, how this might impact their world. Mm-hmm. But how does it impact the organization and individuals along the chain in that organization? And then how do your solutions, notice I said solutions, not products, right? Mm-hmm. How can you come up with a solution that impacts the critical business needs or the critical practice needs that your customer has? So it's really a different set of competencies, if you will, as compared to understanding your product and saying this is the product I have and this is why you need it.
There's a downward trend in the number of salespeople employed in pharma. So most pharma organizations are shrinking their workforce. They're also changing the makeup of that workforce. And that workforce is shrinking. You got a new set of competencies that they probably need.
Right.
Where would you focus their attention?
Well, we need good comparative data. We need cost effectiveness, cost benefit analysis. The days of quality adjusted life years swaying a P&T committee to make a buy or no buy decision are long gone. We want head-to-head comparison data, not against placebo. And here's the biggest nut, we want them to go at risk with us. Why should I put your product on my formulary, you bearing no economic risk? Why do I need that 10th beta blocker, that 11th ACE inhibitor? We're not going to do it. So we want to know, And you use the word, the system and so on. Well, okay, pharma, bring it on. We'd like you to go at risk with us. And we have a 4-word way of explaining all of this, which is really pithy and easy. No outcome, no income. And we want pharma to be in the game with us. No outcome, no income. Meaning, if we have a readmission, we got to eat it. If we have a hospital-acquired infection, we got to eat it. If we chose the wrong antibiotic, we got to eat it. If we didn't follow through on the chemotherapy and we didn't describe the side effects, and patient can't go home for 2 days, and on and on. So to be at economic risk with us, that's something I would love to see pharma do more of that. I understand the issues, it's complicated. There are some leading companies, certainly Aetna and Merck have gotten a lot of press, but we did a deep dive on the at-risk contracts just a few months ago for a national conference here in Philadelphia. It was very hard to find real data. There's very little published information on providers and pharma going at risk together. Everybody else
What
will
do you
fall
think
in
the commercial
step.
insurers are doing, right? So
Yes.
you see the Aetnas and others going to these performance-based arrangements with clinicians. So all the more reason that sellers in today's marketplace, to hit on the words you were talking about,
Yes.
the process has become so much more complex.
Sure, Brad, and why should providers go it alone, right? It's
Right.
all about the system.
Yep.
So the system we already established, it's about 10 cents of every dollar is drug-related, pharma-related. So we want you to be in the tent with us, and we want you to feel our pain, and appropriately, we want you to share in the gain. Look, we're also facing lots of internal behavioral issues. So in today's crazy upside down, inside out reimbursement model, one guy's waste is another guy's income stream, right? Let's give a concrete example. So right at this moment, all kinds of unnecessary tests are going on, even in my health system, all right? Across our 14 great hospitals. And we know that tomorrow a bunch of 40-year-olds are going to get a inguinal hernia repair, and they're probably getting pre-op chest x-rays and pre-op EKGs and all kinds of blood work for which there's no scientific evidence whatsoever that they need it. So that's the waste, but it's also the income stream for the lab, for radiology, for cardiology to read the EKG. So we've got to break that crazy cycle. If I give you a bundled payment, you're going to be more parsimonious about which test and which person and what's the evidence. You're going to go back and look at the evidence before you make a decision. That's where we got to go. Hey, I know it's a hard job. We've been at it for 3 decades, but now we've got this platform is engulfed in flames. It's not just smoking.
Yeah.
We got to get this done.
Is there an opportunity to arbitrage that risk? In other words, let's play like there is a secret sauce in there somewhere. Let's play like there's a magic analytics bullet.
Yeah, we wish there were, right?
Let's play like there is. I bet it would emerge from a college of population
Let's
health.
hope so. What a great opportunity.
So those well-trained students
Yes.
going out in the world that will
Gonna figure it
transform,
out.
one of them will land there and make this right. But if they could achieve a substantive difference in PMPY, is there then not an opportunity to somehow bundle that into a financial product?
Sure. So let's not forget, lots of people are on the margin of this activity right now.
Right.
So XG and Geisinger trying to sell their secret way of doing things to achieve a good outcome. You've got Intermountain and Ascension want to have their own generic drug company, right? Okay.
Yep.
You got CVS, Aetna in a potential, deep merger partnership. So the Aetna doctors are going to drive the Aetna patients only to the CVS to fill their script, get their face-to-face counseling. So sure, I think there's a lot that can be done. If the ABCs can garner some other lessons from other companies that have already made progress in this area, keeping the well, we know that from 50 years of work on Dee Eddington's part at the University of Michigan. So number one, we got to keep skinny people skinny. We know that. Got to keep the healthy. They're role models for everybody else. Okay, so the corporate gym and all the rest. And then we've got to get the CEOs totally engaged, because if I see the big boss exercising, losing weight, I know I'm going to do that. If I give enough financial incentive, not just $100, but you give people $100, they'll stop smoking. So there's a lot we could be doing. We got to make it a priority. And I think there's a tremendous opportunity.
We get into this situation, massive change, shrinking sales organization.
Right.
So each individual contributor has to be better.
Right.
We have this massive discussion in the marketplace, but you got to get out there and you have to improve day-to-day competencies.
Yeah.
Tell me a story about that. Give me an example of improving day-to-day competencies.
Okay. Well, first of all, let's talk about that decrease in the size of and let's just speak pharmaceutical reps, right?
Yep.
So over the course of 5 to 7 years, it went from 112,000 to down around 70,000.
Yeah.
Now, why is that? Because we'd gotten into this, we'll call it a share of voice model, right? Where the more times I say my product name, the higher the market share has gone. And what's interesting is for years that worked. But all of a sudden, the system started saying, look, I'm receiving no value from this. In fact, you're taking my time and costing me money. So that's when we started seeing a lot of the decrease, and it went pretty quickly. So now, from a day-to-day perspective, I'll give you a good example. So there's one of the nation's largest community and home healthcare organizations, right? They knew they needed to adapt to what their customers' expectations were based on the changes that were in the marketplace, right? Show me evidence. And by the way, can your sales representative speak that language? Show me the evidence and understand my complex sale, which is more closely related to a business-to-business type sale now, as opposed to that single stakeholder decision maker, right? Right. So, yeah. So now you have to help organizations, and this is what we did for that large home and community healthcare organization. They changed their go-to-market model. So they shifted their representatives around to match today's marketplace. So that's one issue they had. The second is the competencies needed to meet what the expectations of their customers had changed. So two different things. They changed their sellers' roles, which caused a misalignment of some competencies, and the marketplace had changed. The expectations of their customers had changed. So in order to help them close those gaps, we really went in and helped them design we'll call it a buyer-focused sales process, if you will, right? So how does your customer buy? What's the process through which they go? And then, by the way, what competencies are needed to execute on that sales process? Well, we know the competencies, but the challenge is they didn't know the proficiency level of all their representatives, given the changes they had made. So we helped them assess their sellers against the proficiency level for each one of those competencies. Wow. All right. So then you have a roadmap. So you begin to put performance development plans together for each role, and then train to those key competencies that are driving the outcome that they're looking for. And then, as I said earlier, you reinforce. It's not a one-time deal. You reinforce it continuously, and then you have to measure the results. Is it working? Yeah. So it's a change management piece.
Yeah, but I think, listening carefully to Brad, it's still all about selling the pills. I get it. That's what makes America great. But what I think we got to move to is, look, I'm going to buy your pill, but you got to achieve value with me in the new world order. And we're going to do that if you bring me good data, real world data about the efficacy, efficiency, of course, and the safety of the drugs. I think we're past the safety and efficacy. We want to know efficiency, effectiveness, is it working in the real world? Yeah. And then we want you to go at risk with us. I think that's where we have to go.
Question.
It's going to be hard.
Quick question.
Go ahead.
What level, I know you said it's been a while since people have actually called on you at a sales representative level.
A long time.
But just from your perspective, what level of capability do you think today's sellers have to discuss clinical data and even to begin to understand what real world data is and to integrate that into discussions?
Does vary from firm to firm. We won't name names, but the global companies are heads and shoulders above mom and pop, no question. They've spent a lot of money to get to that point.
Sure.
Even with that, and these are all very bright people, we're not disparaging anybody individually. What I'm suggesting is that I can get the clinical information from any number of sources. I don't need a face-to-face download. What I need is, look, Dr. Nash, I'm willing to help you with a project to test whether this was a good decision to put product ABC on the formulary as opposed to product XYZ. And I'm willing to invest in helping you gather the data. And I'm willing eventually to potentially go at risk with you. You bring me somebody like that, I'm ready to embrace them and do business with them. And I think the other, smoking gun here is the PBM role, the discounting, the middleman. The average American has no idea that 3 or 4 companies have every prescription every doctor's ever written on file. They know exactly zip code by zip code in this town, what's working in this zip code versus what's working in this zip code, and in every other town. So, I'd like to understand that data. If you brought me my own information about how we're writing scripts and we fed that information back to the script writers to achieve a change in behavior, that's a great partnership opportunity. Lots of companies don't want to touch that.
Interesting.
Why is it that pharma has such an anxiety about taking on risk? What's the exposure there we sought very hard to get pharma to come talk about a risk-bearing strategy in supply chain, and there was a reticence to have that conversation. What were we picking up on?
Well, that's a tough issue, certainly explosive issue. As we already mentioned, some of the big organizations that come to mind, Aetna, Merck, and others, have had some modest success. Lilly, some modest success. I think a couple of things are standing in their way. So first of all, lots of lawyers. So that's always a challenge, I think there isn't good head-to-head research data because they've not been compelled to produce it. They've been compelled to produce product to placebo, not product A to product B. So we don't really have the research evidence. That's part of the problem. Then I think there's fear of the unknown. And then I think a final really important reason is what I'll call unexplained clinical variation in doctor, nurse, pharmacist decision making. We know that where you train and where you work is a huge driver of how you practice. So something might work for Pharma A in Philadelphia is going to bomb in Nashville with the same product. So they're reluctant to create a national strategy when there's so much inherent variation. I get all that. So we've got to reduce variation, reduce waste, look at the practice guidelines, practice based on the best available evidence. This is a lifetime's worth of work. So summarize, I think pharma has some pretty good reasons why they don't want to go at risk. It's highly variable in the marketplace in the real world. There's very little research evidence on head-to-head trials. And I think they're keeping their powder dry because they know that 10 cents, 15 cents is at risk today. Why go out on a limb for 10 cents on the dollar? When we're at 50 cents, 60 cents, they might jump in the pool with us, so to speak.
There was a very interesting chart that you showed at American College of Healthcare Executives last week.
Yes.
It was a chart where you showed the portion of total social spend towards healthcare versus all other social spend. Can you talk about that concept for a moment?
We know, and certainly all of the scholars in population health, including a handful of our faculty, have made great contributions that it's all about poverty, crime, lack of education. These are the principal drivers of ill health in our country. And of course, lack of access. If you put together lack of access, so no universal access, and poverty and disparity in income as a part of poverty, this is a toxic brew that leads to poor health. Let's look at Philadelphia, right? So we've got a 20-year disparity in lifespan against 2 zip codes that are 5 miles apart. 20 years, 88, you're going to live to 88 if you grow up in Society Hill, not too far from where we're sitting right now. Get in a taxi with me, go up Broad Street, 5 miles max, 68, 20-year difference. So look, poverty is the key driver. So the things that battle poverty, the social services, Meals on Wheels, maternity and paternity leave, job training, all of that soft stuff that the rest of the Western developed world spends a lot more on than we do is predictive of better health. It's not about the hospital. It's all about social service as a predictor of health. So it's a sobering issue for our country, since especially in Philadelphia, where healthcare is our biggest business, we've got 5 academic medical centers right in this region, got the 2 largest private medical schools in the country right here. So we call it meds and eds, medication, medical system and education. Meds and eds is our biggest industry in the nation's founding city. And yet, if you look at a map of Pennsylvania, and you were to rank every county in our great state, there's 67 counties, I'm mortified to tell you that Philadelphia County, where we are sitting right now, is number 67, meaning the least healthy county in our great Commonwealth, despite the fact that we got 5 academic medical centers right here. So it does beg the question, Brad, what's our core business, right? Are we in this to improve health? I'm not going to answer my rhetorical question because it's too explosive. Right. But social spending is where it's at. Yeah. Healthcare spending, that's 20% of the story. Social spending, the other 80%.
Tell me more about that social spend. Is it really all about the social spend?
Programs like Meals on Wheels, appropriate work-life balance, all of that. The rest of the Western world is way ahead of where we are. Certainly, that's a big part of the jam that we're in. If you look big picture, National Academy of Medicine, right? 18% of the GDP, what's the return on that investment? Well, we're number 17 in the world. In any self-reported measure, all the research measures related to health and wellness. So we're not getting a return on our investment. So certainly social spending is a big chunk of that challenge. But I think there's a darker, much more difficult part of the challenge, which is internal to our business, and that's reducing waste. So Don Berwick, of course, creating the Triple Aim now 10 years ago, I think if Don were sitting here, I bet he would say you can't resolve the cost crisis by focusing on the cost. You got to resolve the cost crisis by reducing waste, practicing based on the best available evidence, and reducing medical error as a part of reducing waste. So if we use the right evidence, if we reduce unexplained variation, if we practice systems-based care, reduce waste, reduce error, what's the goal? Well, then we can transfer some of that $1 trillion of waste back into the system. Wouldn't that be wonderful? Imagine if we could just achieve universal coverage. That would be a tremendous accomplishment. We were on our way with the Affordable Care Act. Almost 20 million people have insurance that they didn't have in 2008, but we are actually seeing that erode. From 2017 to 2018, fewer Americans had access to health insurance. We're making progress, and now we're taking a about face. So, social spending is a big part of it. There's plenty of blame to go around. That's the punchline.
Right.
Evidence.
Yeah.
How does that play into what you're doing?
Yeah, that's a great pickup. Evidence is a large part of the changing expectation of healthcare buyers. Mm-hmm. No longer is the day that a sales representative can show up with a Fifth Avenue glossy and start talking through their product, right? The expectation now is that a sales representative understands clinical data and how to speak the language, if you will, of evidence-based medicine. So being able to discuss the validity, statistical significance, and clinical relevance of clinical data as it pertains to that particular individual buyer or that particular system is one of those key competencies we were talking about earlier. Mm-hmm. That's been one of the shifts that has, some organizations, as you pointed out earlier, are better than others at it. But still, the emphasis hasn't been placed on that being one of the primary parts of the discussion. Mm-hmm. So there's a certain language to it. And there's certain, I mean, for heaven's sakes, there are curricula all throughout med schools that are focused on evidence-based medicine. And now you have to teach 5 levels of evidence-based medicine competency to even be an accredited postgraduate med school. So it only makes sense then if regulatory changes are pushing physicians to drive to using the best available evidence, then it makes sense to speak the language, right? So,
yeah. Well, here's another challenge with the evidence, right? So, if you believe all the lifetime's worth of work of people like David Eddy and Paul Batalden and an army of super smart folk, 18% of what we do at the bedside, plus or minus 2%, has got grade A evidence, right? Randomized controlled trial evidence. Right. So let's translate. 1 out of 5 decisions, we got it nailed. 1 out of 5. So 4 out of 5, that's the art of medicine, right? Now, I'm never going to disparage the art of medicine. A bolt of lightning from Maimonides is going to come down and get me. But let's be real. That 4 out of 5, that's expensive, highly variable. Oh, and by the way, dangerous, right? So we got to find a way to improve the evidentiary basis. You know, a long time ago, I sat in a room with David Eddy, super famous, and he took Schwartz's textbook of surgery and Harrison's textbook of internal medicine, went chapter by chapter with this audience, showing that even the references were largely based on expert opinion. That most of what is in the guiding to big deal textbooks in their 20th edition is largely still grade D evidence, expert opinion. Let's not ever forget that. So when we have the evidentiary basis, well, that's swell. You want to see 2 doctors go at it. Let's get into, node negative breast cancer, PSA that's gone in a white guy from 2 to 3. I mean, we could have a fist fight. Sure. So the evidence is wonderful when we can find it. I think that goes back to your previous question about pharma's reluctance to get into the risk bearing because they know that the quality of the evidence, not so great. Are you willing to hang out in a risk environment with us when 18% of the time we've got it pinned down? I get that. I feel their reticence, and I think it's in part justified.
It's interesting, just a quick point. And if someone in the marketplace on the commercial side of things understands how to look at the data to pull out that lower graded evidence, right? If they understand the hierarchy of evidence, if they understand the different study design types, the different bias that each type could lend to
well, that would be a value.
Right. And so when we talk about clinical selling skills, that's actually what we're talking about. We're actually talking about bringing sellers into a realm of understanding the inverse relationship between validity and bias.
Yes.
And how to understand a clinical trial based on, and actually how to critically appraise it.
Great.
Right? So that they understand where the holes are.
Well, I think understanding the quality of the evidence and being able to evaluate the clinical trial data is certainly an important skill set. We probably don't spend enough time in medical education on those issues, and nursing and pharmacy to boot as well. So I think that's a great skill set that you can teach the reps to have a much more informed conversation, recognizing that the evidentiary basis isn't always there.
Sure.
And at a tiny marginal difference, one product to another, non-inferiority, it's vexing for folks in practice. And I'm a good example of that because, I'm rounding third base now. And at 62, it's awfully hard to change your behavior. It's deeply ingrained in my DNA what I do in that examining room. And I'm only in the office now. I don't do any hospital medicine anymore. And even in the office, it's a challenge. I mean, do I know every new drug for type 2 diabetes? Do I know every new oral anticoagulant? Heaven no. So I'm out of date. And it's hard to keep up. Am I going to get that from a rep? Probably not. I've got to go to the CME. I've got to talk to my junior colleagues. I have to read and stay current. It's a tall order.
Who's the stakeholder In the pharmacy supply chain, who has the greatest economic incentive to go at risk?
Wow.
Who's going to jump out? Because at the end of the day, it's got to have shareholder value, has to be created.
I think it was a great question. So my answer to that would be the folks who are creating the most expensive products for a limited population. They have more of a controlled environment, right?
Yep.
They got more money in the game with a limited number of persons for whom there may really be a great potential positive outcome. Look, you're in a town where we've got gene therapy, the first such company of its kind, right? $450,000 per eye for a certain inherited blindness, right? So if you're going to spend that kind of dough, it better work. So are they willing to go at risk? And I would say the answer there is yes. Yes, they are. So is every mom and pop a generic beta blocker company going to go at risk with me? No, and I wouldn't expect them to. So I think we could have a hierarchy of companies, most expensive product, limited number of potential patients, real dichotomous outcome, work that didn't. I think they have an opportunity to demonstrate some really fantastic sharing of information and risk sharing as well. Now it's 3-4 years from now, and we're in a much more broader bundled payment environment, and I've got heart failure bundled payment and coronary disease bundled payment, and now you're talking, hundreds of thousands of patients, right? I'd like to see pharma have some more skin in the game with us in our care of those patients, reducing readmission, care coordination, all of that. I hope I live to see it.
Yep.
I'm very blessed to have twin 30-year-old daughters and a son who's 27, and we got one daughter is in medicine, and my physician wife and I are living vicariously through our one daughter. But I'm of two minds. On the one hand, her undergraduate medical education looked a lot like Esther's and mine.
Okay.
And that was 40 years ago, right?
Yeah.
So
meaning the biology
that's exactly
and the organic
right.
chemistry.
And memorizing inulin clearance and the clotting cascade, even saying those words reduces my gastric pH. So I think I'm...
genuflecting.
So, that's right. So that's one observation. But I'm also excited because, for better or for worse, our generation has made a mess of it. And I have faith in these new, young, incredible, well-trained, super socially aware, a lot of women doctors. So I'm excited about the future, despite all the challenges that we face. You got to be able to put your head on the pillow at night and be optimistic that we're going to figure this out, because we've got to. So much is at stake. Other than national security, I can't think of a more important issue for our great country than making sure we got access of every citizen to healthcare when they need it, and when they do get it, it's safe and it's cost effective and it's of high value. I'm going to be thinking about this, until life is over. Super important. I hope we get there.
Dr. Nash, Brad Ansley, thank you so much.
Thank you.
It
was a pleasure. Thanks.
Thanks a lot.
Thank you for joining the Business of Healthcare. You can find us at www.bohseries.com or by searching on Business of Healthcare wherever you listen to podcasts. We'd love to hear about your innovation proven to elevate healthcare mission and margin. Join us next as we continue our series on innovations in pharma and device supply chain contracting. Our videographer was TJ Ingracia. Our production assistant was Nat Sharp. Our research assistant was Amy Lamb. I'm Matthew Hannes, founder and executive producer of Business of Healthcare.